Is it their brain or is it their neck? Your body's stuck in fight or flight mode. The signs and symptoms of whiplash are the exact same as the signs and symptoms of concussion.
When I get anxiety before seeing concussion patients.
Is this a concussion problem? A CT is not due to concussion, but it's due to repetitive head impacts. Literally half of their symptoms were just related to the anxiety of not knowing what's going on.
You have this, there's nothing I can do.
Peak head acceleration occurs in the first 20 milliseconds. It's the #1 predictor of bad outcome. It's very simple once you kind of understand how it works.
Welcome back to the Best of Both Worlds Health and Performance podcast with me, Matt Winter, Doctor of Physical Therapy. Today we are tackling concussion head on. To do that, I'm joined by Dr. Cam Marshall, researcher, chiropractor, and educator, and one of the world's leading voices in the sphere of concussion. He's also the founder of Complete Concussions, a network of clinicians providing evidence-based concussion care and a platform that educates them. With a strong background in neuroscience and sports injuries, Cam's dedicated his career to closing the gap between the research and real-world clinical practice. I'm really excited about today's discussion, not just for the healthcare professionals and clinicians listening, but also for athletes that may have sustained a concussion and parents and coaches, those who care for children or are concerned about their brain health as they participate in activities and sports. We're going to unpack exactly what concussion is and how it affects the brain and body, and deal with some of the more controversial topics such as CTE and subconcussive blows. Welcome, Dr. Marshall. How are you doing?
Good. How are you? Thanks for having me.
Good. No, absolute pleasure. Let's crack on with the basics. What exactly is concussion? What is happening to the brain in that process?
So concussion is a functional injury, and basically it just changes how the cells of the brain function for a period of time. It has to do with kind of ion balances, and then also it results in kind of an energy deficit. So, if I go into normal kind of brain function, you have sodium, potassium are the main kind of ions that are in our brain, and they move back and forth across brain cells, and that's what allows brain cells to be able to kind of fire and discharge. And when a concussion happens, basically the brain tissue gets stretched, and so those individual brain cells get stretched. And when they do undergo that kind of stretching process, there's little pores on those brain cells that open up, and then what you get is you get a transmission of those ions across the brain cells. So basically it causes electrical discharge in the brain. Now that's a normal physiologic process, but when it happens due to concussion injury, you basically have that happening to, millions and billions of brain cells simultaneously. That's not a normal process. And so what happens is you get those immediate kind of signs and symptoms, right? Somebody gets hit, they may complain that they're seeing stars, you may see them off balance for a few seconds, they may be confused and disoriented. That's because there's just so much electrical activity going on all at the same time, and your brain can't make sense of it, right? So they can't make sense of kind of what's going on around you. And ultimately what that results in is there's, some other chemical processes that happen, but what it results in essentially is the ability for the brain cells to produce energy becomes impaired. And that impairment lasts for 3 to 4 weeks after the injury. And that's where you get kind of the lingering effects of concussion, is due to that kind of energy deficit. Now, the good news is that we don't really have any good objective evidence of damage to the brain. So it's a functional injury. It changes how the brain processes information. It changes how the brain works. It changes how the brain functions for that period of time. But we're not actually tearing brain cells. We're not, creating physical damage to the brain. Now, there's some speculation around kind of this microstructural damage, where maybe there's things that are happening that are so small that we can't see them, and maybe that's resulting in some long-term effects. But there's kind of mixed evidence on that right now.
And is that where people are trying to look at things like functional MRI studies?
Well, so functional MRI studies are not necessarily looking at that. They're looking at more so global brain networks. So looking at what areas of the brain become active during certain tasks, right? If I give you a task, certain areas of the brain will kind of light up. So it's looking more on a global level to see where those differences are. Now, the trouble with those types of functional imaging modalities is that this type of dysfunction can happen for a variety of reasons. So people with anxiety disorders, for example, can have similar fMRI patterns to people with concussion or persistent concussion symptoms. People with post-traumatic stress disorder will have similar fMRI findings to people with concussion, right? So there's a lot of different things that can change those kind of global networks and how they function. And so it's not necessarily reflective of concussion, but we do see those changes after concussion injury. Now, is that a result of increased anxiety after concussion? Is that a result of the injury itself? We're not sure.
Okay, so I guess that makes assessment a little bit more challenging when we don't have clear visual objective measures. And maybe that's why we struggle in the conventional medical training to make a diagnosis of concussion particularly convincing. Is this why it's difficult for sports medicine physicians, physiotherapists, people without specific training to assess concussion? Is this why we're potentially managing it badly?
Yeah, possibly. I think that there's a whole bunch of issues because you have even people that have a lot of training in concussion. It's still ultimately a clinical diagnosis. Like, we don't really have any objective ways of confirming, right? People are working on blood tests. People are working on saliva tests. People are looking at these imaging studies, but they're finding that it doesn't really correlate with symptoms. It doesn't really correlate necessarily with concussion because you have overlap of all these various conditions. Even like EEG studies, when we're looking at kind of brainwave patterns, we see the same things we see in concussion as we see in a variety of other conditions. So it's like it can't be specifically, attributed to concussion injury. So it's still a clinical diagnosis, meaning we're basing it on signs and symptoms. But, for example, the signs and symptoms of whiplash are the exact same as the signs and symptoms of concussion. So just because somebody got hit in the head, is it their brain or is it their neck? Well, we don't really know. So it's kind of one of those things where I don't want to say a diagnosis of exclusion, but it's essentially just kind of a clinical presentation. So if somebody has signs and symptoms, we're going to call it a concussion injury. Now, was it actually concussion injury? Well, we don't have any way of really confirming or denying that it was or wasn't. So we're going to call it that, and we're going to treat it like such because there's increased risk for not doing that or missing it. So we tend to kind of probably overdiagnose it at this point, but I think that's still better than underdiagnosing it.
So if we don't have these kind of, as you say, objective measures, then what's the safest way to return an athlete to sport? I mean, for example, World Rugby have pretty clear guidelines on that at the moment. Do you think they're good enough, or can we be doing more?
Well, I mean, the World Rugby guidelines are basically the same as the Amsterdam guidelines and most other guidelines around the world, which basically takes a structured return to play, a staged or phased return to, graduated return to play. And usually that's based on symptom provocation at different levels. So, for example, you want to be you want to have your first kind of 48 hours to kind of chill and take it easy. Then you want to start back into some light physical activity. And, if that doesn't provoke symptoms, then you can move on to kind of more structured sport specific activity. And if that doesn't provoke symptoms, then you know what I mean? So it's all just looking at symptom provocation. That's currently the best, thing that we do have. One of the best things that we think should be kind of mandatory across the board is having good, baseline measures. So I mentioned you can't use imaging, you can't use blood tests, you can't use EEG. But one of the best things you can do is we can test function. So we can look at things like memory, concentration, ocular motor function, all these different visual processes. We can look at, cognitive function, reaction time, that type of stuff. But the problem with that is you have to measure it before the injury occurs, because what you're looking for is changes in an individual. With normative data, we can't, it's difficult because with normative data, you end up with a range of normal that's so wide, right? Like if I was to look at everybody, if I was to take a rugby team as an example, and I look at everyone's balance at a given point in time, I'm going to have people with like really exceptional balance, and I'm going to have people with, poor balance. But the range of normal now is this wide. So let's say you get injured and your balance after the injury is, let's say down here. You're actually within the range of normal, but is that normal for you? Well, we don't know, because we don't know if you were one of the exceptional balance people or if you were one of the poor balance people, and you're actually back to normal now, because that's normally where your balance is. We don't know that unless we knew what your balance was pre-injury. So that presents challenges, obviously. Now, if you're working in a professional setting, they do this type of stuff every year. But if you're working in kind of a youth rugby level, the funding isn't there necessarily for teams to do this type of stuff. There aren't practitioners, enough practitioners that are doing this. I mean, all of our clinics are doing this on a regular basis with all the youth teams that we work with. And we just measure people every single season, whether they had a concussion or not. We're just measuring them so that we have their most recent kind of baseline data, so that in the event that an injury happens, we're not just relying on symptoms, because symptoms tend to go away before the brain recovers, right? I mentioned that brain recovery takes kind of 3 to 4 weeks. The symptoms of concussion typically last, a week. So after a week, your symptoms are gone, but the function of the brain still has not recovered yet. And so a lot of people just relying on symptoms, especially people that are kind of untrained in this and they don't understand, like many physicians or healthcare practitioners that don't have any concussion training, they're going to assume that, okay, well, the symptoms are gone, then that means the injury is gone, right? The example I use here is the broken arm. I use this all the time. So if somebody breaks their arm, it really, really hurts, right? You go to the doctor, they can x-ray it, and then they're going to put a cast on you. And but after about a week or so, the arm doesn't really hurt anymore, right? Does that mean that the bone is healed? Well, no. Does that mean I can cut my cast off and return to sport? No. Right? What's going to happen? You're going to go back and the doctor's going to take another x-ray and they're going to say, well, healing started, but it's still broken, right? So you got to keep the cast on. And they're going to keep doing that until they see sufficient healing in that bone before they'll say, okay, now you can take the cast off. Now you can start gradually returning back to sport. With concussion, we don't have that. We don't have our x-ray. We don't have the MRIs. We can't see any injury at all. So we don't know when it's returned to normal. So the best thing we could do is test the function. But in order to do that, we have to know what the pre-injury function was. And that's kind of the challenge here. And if we don't have that pre-injury function, we're essentially just guessing. Have they recovered? Have they not? Well, we don't know. Everyone's recovery timeline is a little bit different. We don't have the x-ray to look at it. But if we were to approach it in this way, where it became kind of a mandatory part of sport, and I don't mean something like a SCAT test, right? A lot of people might be familiar with the SCAT test. The SCAT test normalizes before the symptoms go away. So the SCAT test is a basic sideline assessment tool. And it does not tell you when recovery has occurred because it's not sensitive enough to do that. It's sensitive enough to pick up acute deficits immediately pitch side. But after the first 48 hours to 72 hours, the SCAT, all those tests in the SCAT will have normalized back to baseline levels, even though the injury is not recovered for another, 3 weeks, 4 weeks. The symptoms will not even be back to normal by the time the SCAT normalizes. So the SCAT's not going to be helpful in terms of making a return to sport decision. What you really need to have is like better, more sensitive tests, and you have to have a battery of things where you're testing multiple areas of brain function. So that, okay, you're going to go through your return to sport. So this is how we handle it, just to kind of put that into a frame. Injury happens, we assess it, we rule out red flags. We want to make sure there's nothing more serious than a concussion, right? The initial stages, you're not concerned about the concussion, you're concerned about something else. Is there a fracture? Is there a spinal injury? Is there a bleed, right? Do we have, like something that could be fatal? That's what we're worried about, right? And then after that, once we rule all that stuff out, we're going, okay, now we're into concussion territory. So we're going to have our, rest phase. We're going to gradually work into exercise, and then we're going to kind of go back into return to sport. Once we hit that kind of stage, 4, where it's getting into like more complex non-contact training drills, you want to be asymptomatic at that point. You should be asymptomatic with rest, asymptomatic with cognitive activity. You should be back to school and everything else before you continue on the return to sport path. And then we're going to do a medical clearance evaluation. where we're going to physically exert the athlete to kind of maximal levels. So we use a test called the Chicago Blackhawks test. It's also called the Gapsky-Goodman test. And it's basically an intensive physical exertion test that mimics a sporting environment. So there's things like burpees where they're up and down, they're jumping, they're spinning, they're doing lateral kind of hopping drills and things like that. We're trying to provoke symptoms to see if anything's there. If nothing's there, then we immediately, in an exerted state, because it just increases the sensitivity of the measures, we then will go and test reaction time, cognitive function, memory, concentration abilities. We'll test balance. We'll test, ocular motor function. We'll test a whole battery of things, and we'll compare it to their pre-injury levels. And what we often see there, about 15% of people will just outright fail the Blackhawks test. Right? So 15% of people that are asymptomatic and would have been cleared to return to sport in any other scenario, 15% of them fail the Blackhawks test. They have symptom provocation with that exertion test. Okay. If we take the other 85%, about half of them fail one or more elements of their baseline. Meaning that all in all, basically 50% of people that are asymptomatic and would have been cleared to return to sport at their medical clearance evaluation fail some element. So if we're not doing that, we're going to be missing about half of these concussions and returning them to sport, far too soon. So that's probably the best way of doing it, is to have really good objective tests and tools that you can use and rely on. Because what you want is something when the symptoms go away, can we still pick up these dysfunctions? And those are the tools you're looking for.
Brilliant. So what's the risk? I mean, as I said, like, a lot of clinicians don't have these tools, or they're not used to using the Blackhawks, and they might be using World Rugby guidelines, sending people back, for example, at a minimum of 21 days in Singapore. What's the risk if they're symptom free, they go back at 21 days, if they should have another concussion in the next week or two? What are they looking at?
Well, then you increase the risk for the cumulative, aspect of concussion. So I mentioned the concussion is kind of a metabolic injury. So it affects the mitochondria in the cells and their ability to produce energy, ATP. And that ATP level is low for that kind of 3 to 4 week period. So the 21 days is a decent guideline for that, because it gets you kind of almost to the end of that, right? So that first week back is probably your most critical, because what the evidence shows is that if you fully recover from that concussion from a metabolic perspective and you get another concussion, well, it's just another concussion, right? We don't get that same additive or cumulative nature. But there's been a whole bunch of animal studies and a few human studies that show that if you do get a concussion within that kind of critical window when recovery is still ongoing, you actually end up now dropping even further down in your ATP. And if you drop further down in your ATP, now you can actually start to create some permanent damage, because once those energy levels get too low, the brain cells actually begin to die off. They go through a process called apoptosis, where they actually kind of kill themselves off because they don't have enough energy to sustain themselves. And then you can get cerebral edema in young people, especially. Like, this can actually be fatal. It's called second impact syndrome. It's a very rare event, but when it does happen, obviously it's terrible. In adults, we don't have any evidence of true kind of second impact syndrome, fatality type things, but you still get now a cumulative nature. So the thing I always say is, like, when we talk about things like CTE, is this a concussion problem, or is this a concussion management problem? Is this just the fact that we're sending, high level athletes back into sport too soon after their first injury, and now they're just getting them and getting them and getting them and getting them, and it just keeps cumulatively adding up, and they're getting permanent damage now to the brain? What would happen if we were to say, okay, we're not going to just rely on symptoms anymore, but we're going to rely on objective measures and make sure that recovery has occurred prior to sending them back? Do we get that cumulative effect? Do we get that actual damage to occur? Based on the evidence, I think that would make a huge impact in this type of stuff. Just being able to say, okay, we're going to be more objective in how we do things. So for the practitioner that's using the guidelines, is just going, okay, 21 days, all right, you're asymptomatic. Meaning, even though symptoms don't mean anything. But if they were going to rely on that, if that person gets a concussion within that first week or two back, there's a good chance that they weren't fully recovered from the first one. And there's a good chance now that that injury is going to be worse, right? Same with the broken arm. If I cut my cast off and return to sport, well, now I'm going to break it. It's going to be worse. I may need surgery. I may need pins and plates and all sorts of things to try and secure that, because I've just made it. I took a simple fracture and turned it into a complex compound fracture that now I have to deal with, right? So it's the same kind of thing with concussion, I think, is that if you're going to not deal with the initial injury in a proper way, you're probably going to end up with some downstream effects that are going to be a lot more detrimental.
Just as a rough guideline, if someone does get a second impact in that period of a metabolic crisis or an ATP deficiency, what are we looking at in terms of the second concussion? How much longer might that be, and how does that compound over time?
So there's only been really one study on this that can kind of shed light. And it's very difficult to study this, right? Because we can't just take people and put them into harm's way knowingly. So we have to kind of rely on observational data and kind of, case series and case reports of these types of things happening. But kind of the best evidence for this shows that the longer time between injuries, the better. That's kind of a general, thing. And if you are, like, for example, if you get your second concussion 10 days after your first, you're now looking at symptoms for around 60 days or so, rather than like 10 days. You're looking at symptoms for about 60 days. But even then, even if you were, again, to rely on symptoms, when the symptoms go away 60 days, okay, I'm going to let this person play, the metabolic recovery in that individual doesn't come back for 120 days. So the normal process is like, 3 to 4 weeks. Now you're looking at, with that second concussion, you're looking at 3 to 4 months. Now, what happens if they get another concussion in that 3 to 4 month period? How long does it last then? We don't know. Now, taking that same thing, if you were to get your second concussion at 10 days, you're looking at, 120 days. If you were to get your second concussion at 21 days, like let's say your first day back, you get another concussion right at that 21 days, you're still looking at metabolic recovery of the second concussion of now 60 days. So we're still not out of the woods there, right? So it goes from 30 days to 60 days or even 90 days. So somewhere it's going to be a lot longer, potentially double the impact now. Now the symptoms from that second concussion at 21 days are usually about 20 days. So it kind of doubles. But you're still looking at, now you've created obviously a further injury, a more cumulative impact. You can kind of see it in that.
Does this explain some of the persistent concussion symptoms that we get? So if we sort of move on to that side, there's a group of people, isn't there, that just don't recover from that initial concussion. Can you shed light on some of the numbers there and why that's happening?
Well, so I think some of them are potentially due to second impact type scenarios, but it's a different thing. So persistent symptoms is not due to the ongoing physiological process, right? So you have the initial concussion, you get this metabolic dysfunction. Symptoms typically will last that first week. The symptoms will start to clear. Metabolic process still takes a while to recover. Now, the kind of cutoff point is about the 1 month period. If you're still symptomatic at 1 month, we start to call it persistent concussion symptoms. And what we know through all of the literature so far is that persistent concussion symptoms don't seem to be the result of ongoing brain injury. It's not like this was just a bad concussion that caused the symptoms to linger. Instead, what it is other kind of physiologic dysfunctions that haven't recovered properly. So when you get a concussion, you get things like, autonomic nervous system dysregulation. So your autonomic nervous system becomes disrupted. And your autonomic nervous system controls how blood flow goes to your brain. It also controls your anxiety and stress levels, which helps, which controls how you sleep, how you breathe, how you think, all of these things. So if you have this high sympathetic activation, which happens sometimes after concussion, your body's stuck in fight or flight mode. And if your body's stuck in fight or flight mode and it doesn't rebalance, that can cause all the same symptoms as concussion. And those symptoms can linger for, months, years in some cases if it's not properly addressed. So persistent symptoms are not due to the brain still being damaged, but it's due to some dysfunction that happened when the injury occurred that continues to linger. Another example of this would be, hormone dysregulation, for example. So after a concussion injury, again, that autonomic dysfunction increases stress on the body. That can start to impact your hormone function. So you start to get increase in stress hormone production and all these different things. You can get gut issues, right? So immediately after injury, within about 3 hours, we see that the permeability of the gut actually widens. So we're getting, our gut becomes more permeable, which means there's going to be more inflammation in our bodies. We have a change in the bacterial composition of our guts, which means we're going to get something called dysbiosis, where we're going to get a proliferation of harmful gut bacteria and kind of, a dying off of the good healthy bacteria. And that causes this kind of dysfunction in our guts, which again promotes inflammation. Chronic inflammation can cause mental fogginess, it can cause fatigue, it can cause cognitive problems, it can cause headaches, it can cause all sorts of different things to happen. So people assume, I'm still feeling shitty. This is because my brain is still damaged from my concussion. Well, no, the concussion was the inciting event that caused all these downstream factors. Those downstream factors are now what's driving those symptoms to continue. And the good thing is we can actually treat those. Like you can, if you know what you're doing, you can actually treat those. You can put them in gut protocols. You can, start to balance the autonomic nervous system through basic kind of exercises that you can do and different activities that you can do. Another one that causes persistent symptoms is the neck injury. I mentioned that concussion and whiplash they all happen at the same time, right? Concussion is acceleration, deceleration of the brain. Whiplash is acceleration, deceleration of the neck. Well, the head and neck are connected. So if you're going to get enough force to cause a concussion injury, you're going to get some sort of neck injury or neck dysfunction that happens at the same time. And the symptoms of that are the same as concussion. So a lot of times people with persistent concussion issues are actually just dealing with ongoing neck dysfunction, but the symptoms are the same as the concussion. So they're assuming like I have these headaches and it's my brain, or I feel dizzy and it's my brain. But what they don't understand, and what many healthcare professionals don't understand, is that the neck causes a lot of these headaches, that the neck causes a lot of this dizziness even. And so persistent symptoms are different than the concussion itself. All right. I hope I explained that well.
That's really clear. What's sort of the most important order to approach this? So someone's healthcare professionals listening, clinicians listening, where should they start? Because there's a lot of things to consider there.
Approaching it from what factor? Like with a patient or?
With a patient. There's obviously lots of systems that can be affected. Let's start with, say, the autonomic dysfunction. How would they go about assessing that? Is that the first one to assess, or should they be looking at the cervical spine, for example? So where do we start in terms of hierarchy of needs?
So our algorithm, I had a sheet here somewhere, but I don't know where it is now. So maybe I'll frame it this way. There's kind of 5 main systems that are impacted after concussion, and persistent symptoms can be due to any one or more of those 5. So we have autonomic dysregulation, we have kind of gut hormones and kind of chronic inflammation, we have visual and vestibular issues, we have neck issues, and then we also have kind of mental health. So we don't necessarily have to tackle it in that order, but there is kind of a systematic approach and way of doing this. The first thing we do with any patient, if they have persistent symptoms, or even if they just had a concussion and we want to prevent persistent symptoms, the first thing we do is we start with just patient education, right? Mm-hmm. What is a concussion? It's not brain damage, it's brain dysfunction. Here's why you don't want to return to sport early. Here's your kind of metabolic low. We want to make sure you're over here before you go back to sport. But your brain isn't damaged. It's just going through this dysfunctional period. It's just this kind of low energy state. If they're already in persistent symptoms, we can say, well, the brain part of it, the injury has recovered. And so the symptoms you're experiencing are due to one of these 5 things. And here's how we're going to help you tackle that. And then what that does, because of that education, if it's good enough and you know what you're talking about, the patient will be like, and that 100%. Reduces the anxiety, which gets you, so that's number 5 in mental health, but we're actually kind of going after that one first, right? Because anxiety can cause a lot of these same symptoms to occur. And anxiety can keep our autonomic nervous system stuck in fight or flight. Anxiety can prevent us from getting good quality sleep. Anxiety can prevent us from thinking clearly, right? A lot of cognitive problems after concussion are mostly associated with anxiety and mental health. And so being able to help a patient reduce that anxiety with good education. And you may need some mental health support on here too. We do anxiety and depression screening tools with all of our clinics. And the reason we do that is because they may need a referral for cognitive behavioral therapy or something else to try and kind of reduce that. Because if you can't reduce that anxiety, you're going to have a hard time getting that patient better. So that's kind of number one, is we're addressing mental health through really good education and making sure that, do we need a referral here to start helping that part of the process. So that's kind of number one. Even though I listed it as number 5, we start with kind of that one.
Yeah.
Second, we provide them with the diet and gut stuff early, right? So here's how I want you to eat. I want you to start, getting rid of any potentially inflammatory type foods, because that'll keep your gut dysbiosis around, right? So things that do that are alcohol, processed foods. A lot of people, even if you don't necessarily have a gluten sensitivity, a lot of, gluten type products like breads and things like that can cause persistent inflammation in people. So we tend to get rid of gluten, and we put people on to basically kind of whole foods. That's our kind of mainstay, is just high quality protein, fruits and veg. Stick with that for the next, 3 to 4 weeks and see how you feel. Often people will feel really clear. They'll have more energy. They're not bogged down by all these kind of inflammatory things, these processed foods and whatnot. And sugar is the other one we cut. So we give them that kind of right away. They can start on that. Then we start tackling autonomic. So the first thing with autonomic is that you can have people that are like really dysregulated, or you can have people that are kind of moderately dysregulated. And the treatment approach is different. So first we're going to assess them to see, do they have extreme autonomic dysregulation, something called dysautonomia? Do they have something like a POTS or an orthostatic hypotension that we have to address? Because then we'll go after that first. If they're clear on that and if they don't have any issues there, then we move on to subsymptom threshold exercise. So we'll put them through a Buffalo concussion treadmill test. We'll try to see at what point in their heart rate do they experience an exacerbation of their symptoms. If they do have an increase in symptoms with increasing heart rate, then we know that the autonomic nervous system is out of whack. And so the treatment for that is actually exercise. But we don't want them exercising way up here. We want them exercising below that threshold so that they can start to build it. And then every week we just retest them, get to a new level, give them a new threshold target to work at, retest them, and we keep doing that until they're able to get to full physical exertion with no issues. So that's autonomic. Then we move on to, visual and vestibular and neck dysfunction. And we kind of treat those as a trifecta, because people that are having dizziness issues, it could be their vision, it could be their vestibular system, but it also could be their neck. And so it's very difficult to figure out which one is which. So we kind of assess and treat simultaneously all 3 of those. So now we've tackled all 5 of them. And then from there, you'll have a really good clinical picture. So typically our clinical assessment for somebody with persistent symptoms takes 3 separate visits. So the first one is just history, ruling out red flags, education, and then diet plan. And then visit number 2 is treadmill testing or orthostatic intolerance testing, and then treadmill testing. And then visit number 3 is kind of visual, vestibular, neck. And then now we have a good clinical picture, right? Okay, this person failed the treadmill. They got a little bit of autonomic, so we're working on that. They're doing exercise. I'm going to see them every week to reassess that. And they have a couple of visual issues that we've given them some rehab for, and they need some treatment on their neck, and I'm working on that. So now we have this clinical picture of that particular individual, what's driving them, and then now we have a really good pathway to help them out of it.
Yeah, that's brilliant. I should say at this point, I have done your training. And it has been incredibly, first of all, it was very challenging. It was very, very enlightening. We hear a lot about things like the gut-brain axis out of the sphere of concussion, but to see how it really, really links together here was super interesting. My experience with patients is that they actually really appreciate how slow the process is. Especially if you outline it at the beginning, they realize that they've had symptoms for a while. I'm talking about the ones with persistent symptoms, and they appreciate someone going in detail and step by step, as long as you give that vision of that process at the beginning. I've also found that the education is one of the most powerful tools. As you say, it reduces that anxiety almost immediately. And actually, even with that, some of the symptoms reduce from the first session to the next session, which is unbelievable. The other thing is the sub-symptom threshold exercise. So powerful. Just giving them an objective marker by doing that treadmill test, very, very powerful. So I can 100% vouch for what you're saying there.
Yeah, there was a couple so if you look at just the education alone, typically what we see is that oftentimes someone will come in with a certain symptom severity score, and then you'll do that first visit with them. and then you'll see them for their treadmill test like a week later, and their symptoms are literally 50% lower than they were at the first visit. And that's the anxiety piece.
Yeah.
Right. So now it's like, so let's say somebody comes in with a symptom severity score of like 65 out of 100 and, 32 or whatever it is, 65. And then we talk to them and we teach them all this stuff. And then they come back in the next day, their symptom score is now a 30. It's like, so literally half of their symptoms were just related to the anxiety of not knowing what's going on. And now that they found you and you know what you're talking about and you've explained all this to them, now they're like, okay, I'm not, damaged, and there is something here that I can work on. It just really knocks it way, way, way down. And I think that the other thing I wanted to bring up is that having a systematic approach that's kind of evidence-based, and that's how we do it. That's why we do it in that kind of systematic way, is because you don't know what's going on with somebody. They come in and their symptoms, they may complain of a lot of dizziness, right? So a lot of practitioners will just be like, I'm going to just go right into vestibular rehab. Okay, but that dizziness could be due to that autonomic dysregulation, but you haven't looked at it. It could be due to neck dysfunction. You haven't looked at it. It could be due to visual function. You haven't looked at it. It could be due to anxiety, and you haven't bothered to even educate this person on it. You've just gone right into kind of, dizziness, vestibular. And I think that's a big problem in concussion. I think that's why patients end up bouncing around for years without finding somebody that can actually help them. And it's all about just slowing it down and being like, okay, if you try to do everything on day one, everything's going to bleed into each other. If I do a treadmill test and they fail and they feel like shit, and now I'm going to go right into vestibular work, they're going to be like, and now I don't know what's what, right? So the reason you do it in separate visits is so that you can really break it down and be like, okay, I saw them on this day and this was an issue, this one piece. Okay, now this is also a piece, and it didn't bleed from one to the other because you had enough time in between to actually make a thorough assessment. And then once you have your picture, now you know what you're doing. And then it becomes so easy and so clear, and the patient actually is getting better because you're targeting the right spots. You're not missing anything. So I think that just comes down to the education level, right? A lot of people just, concussion, they get all flustered about and don't know what to do. But if you know what you're doing, then it becomes kind of simple and straightforward. You just do this, then you do this, then you do this, and then you'll figure out what's going on, and then you can go.
Well, I think a lot of it comes down to clinicians' comfort in dealing with it, and they'll often see what's under their lamppost. So if they feel most comfortable dealing with vestibular, they'll be like, "Oh, brilliant! Let's deal with the vestibular side of things." So yeah, I think it's that's where it's important potentially not to go straight to a specialist, and have someone that sees the global picture, sees the big picture, and then of course there's always space to refer to those specialists as needed along the way.
Yeah, for example, I don't do a lot of vestibular work, right? I'm a concussion person. This is all I do. But I have people that specialize in vestibular. So I haven't bothered to become a vestibular specialist necessarily because that's not my wheelhouse. I take a really broad look and I go, okay, you have a little bit of this, you have a little bit of this, you have a little bit of this. And then if part of that is vestibular, I just refer to somebody else that does that part. And so it's really being able to figure out that puzzle. That's the most important piece. Because if everyone just goes to vestibular, actually, a perfect example of this, there was a kind of a critical review that was done looking at vestibular treatment after concussion. And because a lot of patients that, describe dizziness to their physician or whatever, they're going to get referred to vestibular rehab because physicians hear the same thing, dizziness, vestibular, go. And the research on this shows that vestibular rehab for people with dizziness, right? People that have dizziness after concussion, vestibular rehab is only 25 to 50% effective in people with dizziness, right? So you have like a 50 to 75% chance that vestibular therapy is not going to work for you, even if you do have dizziness. And the reason is because post-concussion dizziness could also be due to autonomic, anxiety, neck dysfunction, or visual dysfunction, right? And everyone gets referred for, so there you go. Like basically 4 of the 5 are potential causes of dizziness, and yet you're only going to look at one. You're going to miss it on, 50 to 75% of all your patients. Yeah.
We've mentioned mental health a couple of times and how it can affect concussion. Is it one of the predictors of bad outcome, and should we be screening for this routinely?
It's the number one predictor of bad outcome. Is a pre-existing history of anxiety and depression. And even if you didn't have a pre-existing history of anxiety and depression, even if you had a family history of anxiety and depression, where let's say one of your parents suffers from anxiety, then your chances of having persistent symptoms go up 2.5 times. But also, then even if your parents didn't have anxiety or depression, but now that you've had an injury and it's been, 3 or 4 months, you're still dealing with symptoms, there's a good chance that you've developed some anxiety around it. And the risk of developing anxiety and depression after concussion is about 50% higher than any other injury, right? So if you compare concussion to like musculoskeletal injuries, the risk of suffering from some sort of mental health diagnosis within the next 3 years is 50% higher than any other of those injury categories. So even if you never had a history of anxiety and depression, the fact that you're having persistent symptoms can cause more anxiety and depression, which then causes worsening of that. And so, mental health is one of the biggest issues with concussion, which is why I think that really knowing your shit when it comes to this, if you want to work with patients in this area, like really, really knowing what you're doing, that's the most profound impact, because you can confidently talk to a patient about it. You can confidently answer their questions, because they're going to have questions. They're going to challenge you. They're going to be like, well, wait a minute, that's not what I read on the internet. And you're going to have to say, well, here, this study, da, 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 da. And then they're going to go, okay, fine. Maybe I believe you. And then they're going to kind of calm down. But if you don't have that level of knowledge, they're just going to chew you up and basically not believe what you're saying. And then they're not going to buy into it, and they're not going to get better. And so I think that has a lot to do with it.
I mean, I can completely relate to that as well. I mean, I get anxiety before seeing concussion patients, because I know there is so much to know. And I find myself revisiting your videos over the weekend. I'm rereading the course content the day before, because as you say, that giving the right information calmly, comprehensively to the patient is so important in their outcome.
That's why you said our course was challenging and there was so much there. That's why we do that. Like our goal is to like give you the information to basically make you an expert in this area, and being able to have access to that information ongoing to basically go back and review it and all that stuff allows you to kind of, because it's just repetition, right? Like these studies I'm calling upon right now, it's like I've talked about these so many times that they're right there. And so when a patient asks, I can just pull it up. And the same thing starts to happen over time as you work with more and more patients and continue to review, that information. It becomes ingrained in your head, and you can pull upon it easily.
Another thing that gives, I would say, parents anxiety is the media, essentially. There's a lot of stories increasingly now in the media. There's court cases going on in the UK around concussion within rugby. And then recently, or in the last few years, we've had more and more stories about things like subconcussive blows. So from heading a football, for example. How does that sit with you? Where do you think the evidence is at with that?
I think the evidence is mixed at best for whether that has any real impact or not. If you talk to the kind of CTE people, they're firm believers that this is not, CTE is not due to concussion, but it's due to repetitive head impacts. And they'll do this kind of with like these kind of correlational type studies where, oh, you played football for this long, well, therefore you've probably had this many impacts, and that's probably why that this has happened. But that research is very kind of mixed. At best, some studies show that the earlier you start football, the more likely you're going to have CTE. Other studies show there's no correlation. So it's very mixed. There's been other studies done at, heading in soccer. Well, football for you, your football. Yeah. And some of the studies will show that after, heading sessions, cognitive function will decline by a certain amount in people that were heading the ball. Other studies show there's zero impact on cognitive function after a session of heading. So it's very kind of all over the place. We don't have any clear kind of concrete evidence yet that subconcussive impacts are a thing. It's all kind of speculation at this point. And you have, it's very controversial as well. You have kind of two camps of people that are just kind of screaming at each other. One side is calling the other side a denier, the other side saying the evidence isn't strong. They're saying, what are you talking about? It's all right here. And you end up with a lot of kind of infighting around it. So, I tend to go with the evidence. I'm kind of on the side of like, yeah, it could be a factor for sure. I'm not denying that it can. I'm just saying that the evidence at this point is kind of weak. And that's where I'm at.
What can a kid do or a parent do then if they're trying to reduce the risk of concussion for their kid who's playing football, for example? I remember there was a study done, hopefully I'm going to get this right, was it on cats, where they sort of stabilized their necks and imparted some sort of blow to the head, I believe. It's an awful thought. And they actually reduced, or it stopped them getting a concussion. I think the implication from that is that neck strengthening was important. Is it important?
Again, another one of these things that has a lot of mixed evidence. So from that study, basically what they did is they would swing a pendulum, right? They'd swing a pendulum down and they would hit the cats in the head and they would get a concussion. Everyone
so bad.
Everyone cringes when we talk about this. And then what they did on the second part of this is that they would stabilize the cat's neck. So they would lock the neck in place so the neck couldn't move. And the quote from the paper is, concussion could not be observed even with the maximum velocity obtainable by the pendulum. Meaning, like, I'm just picturing these guys like really jumping into these throws to try and swing this pendulum down, and they couldn't cause a concussion. And so from that, a lot of kind of theory has emerged. Now, this study was done in like the 1940s. So this is like a long time ago. From that, a lot of people have theorized that, well, neck strength, because if your neck is strong, maybe you can stabilize your head better. And so when the impact happens, if there's no movement of the neck, there's no movement of the head. Therefore, there's no acceleration. In order to have acceleration of the brain, you need to have acceleration of the head. In order to have acceleration of the head, you need to have movement of the neck. Well, if the neck can't move, the head can't move, therefore no acceleration. Okay? So neck stability. And there was another finite element study done by Viano and colleagues. I think it was 2007 or 8. And they looked at, they reconstructed NFL football impacts, or college football impacts, using finite element modeling. And they tried to play with the variables, right? What if we increased the helmet padding thickness? What if we, made bigger helmets and harder helmets, or what? And then another variable they looked at is, what if we increased the stiffness of the neck? And the only variable that actually reduced the head acceleration substantially was increasing the stiffness of the neck. So then this translated into, we should strengthen the neck. The problem is that neck strength and neck stability are two different things. Because you can have a really strong neck, but unless you're actively contracting it prior to impact, it's not going to be necessarily more stable, right? Because if I'm an athlete and I have a really strong neck and I'm going up to head a soccer ball, I'm probably going to stabilize my neck in some way, right? I'm going to get prepared for it and I'm going to go. But if I'm just running down the field and I turn around and somebody boots a ball in my face and I'm not ready for it, my head's going to snap back because I'm not actively contracted. So those are two different things. So having a really strong neck, I think, helps if you know the hit's coming. So if I'm a boxer, I'm going to want to definitely train for endurance and neck stability. I'm going to want to be able to tuck my chin and hold my head very stable throughout an entire fight. Like, I want to be able to hold that because I know that punch is coming repeatedly. But if I'm a wide receiver in football, I have to be able to turn my head and look over my shoulder to catch a football. I can't do that no matter what. And so you're not going to know the hit's coming. Most concussion happens when people don't know the hit's about to happen. And that's because they can't stabilize their neck. They can't get prepared for that injury to occur. So does neck strength help? Well, again, the evidence is mixed. Some studies show that people with stronger necks have a reduced concussion risk. Other studies show that people with the strongest necks have absolutely no reduction in concussion risk. More recent studies are more looking at like neuromuscular stabilization, like the ability to contract quicker. Can we get people's reaction time faster? Because in that Viano study that I talked about, from the moment of impact, peak head acceleration occurs in the first 20 milliseconds. So if you're going to get hit, the first 20 milliseconds is when your head hits peak acceleration. 20 milliseconds. Well, in order to contract the muscles of your neck, it takes you like 150 milliseconds to even initiate the contraction of the muscle. Then it takes you another 150 milliseconds to get to half of your contractile strength. And then, theoretically another 150 milliseconds to get to full strength. So you're talking about you need half a second to get your neck up to full strength, yet the injury has already occurred in the first 20 milliseconds.
So it's really sorry.
Yeah, it's about either avoiding the hit altogether, because if you have half a second, right? If somebody's coming at you, you're playing rugby, and you have half a second, you have a decision to make. Do I contract and stabilize my neck and brace for impact, or do I dodge? Because you could do either one, right? So either one I think is good. So then this kind of leads me to think that I would rather train like visual function. I would rather train peripheral visual function. I would rather train game awareness so that people are better off picking out, like you're probably not super familiar with hockey, but I'm a Canadian, so I am. There's all the best hockey players, the ones that score the most goals, the ones that whatever, they don't get hit a lot and they don't really suffer many concussions, even though people are out to get them because they're the star player on the other team. And I think that comes down to they're just so good at what they do that they just know where everyone is on the ice at all times. And so they're able to kind of get in positions that just reduce their injury risk, but also put them in prime kind of scoring, positions. So it's kind of one of those things. Like, do you spend your time focusing on making my neck stronger? Or do you spend your time focusing on, training my visual function or learning kind of game awareness, learning where to position myself to like, I don't know. You could kind of go either way. You could do a combination
and you can do
of
both, right?
You could do both.
It surely doesn't hurt to have both. I guess this sort of links into players' behavior as well as being a predictor for concussion. Their sort of their risk appetite, how they play the game. I don't know if that's something you can actually change, and maybe you shouldn't be changing it, but it certainly seems to be a predictor. I guess the other thing that would be fitness levels. I would imagine as people get more centrally fatigued, their risk of concussion goes up because their awareness goes down. Is that something you see as well?
Again, that's kind of mixed. Like, you see more concussions, for example, in preseason football than you do in regular season football. And I think that's just because people might be coming in kind of maybe untrained, unfit, or just not used to playing, and they're kind of, they're maybe a little bit out of touch when it starts to happen. Other studies will show more concussions towards the end of games. Other studies will show them towards the start of games. You have kind of a mixed bag. Different field conditions matter. So for example, if you have artificial turf versus grass, some studies show grass is actually better because the ground is softer, unless you're playing in freezing conditions, then the ground is harder and then it makes it worse, right? So it's kind of this, everything's all over the place with concussion, and it's hard to kind of get a sense of it. But you mentioned playing style, right? So, I have half a second before impact. Am I the type of player that puts my head down and bowls the person over and tries to run through them? Or am I the type of person that's more likely to juke and get out of the way, right? That's going to probably increase or change my kind of risk profile. And people will go about that different ways. And it's going to be hard to train the person who's used to just boom, and to say, get out of the way. I don't know, that like their instinct is just going to be to do that particular thing.
Yeah, and sometimes second guessing themselves might put themselves at more risk anyway.
Yeah.
All right, let's stick with the controversy as well. We're sort of on it.
Great.
CTE. Okay, I mean, it's something I sadly had an argument with someone recently on a WhatsApp group, a clinical WhatsApp group, where another CTE story was brought forth and discussed. Where do you stand on CTE and the evidence? And first of all, for people listening that don't know what is CTE?
CTE is an acronym for chronic traumatic encephalopathy. It is the kind of neurodegenerative condition that has been attributed to, concussion and repetitive head trauma. It is a post-mortem diagnosis. We cannot diagnose it in a living individual. It has to be done post-mortem when we actually take a look at the brain. And when they look at the brain, they'll find little deposition of a protein called tau protein that develops into these little kind of tangles. They call them neurofibrillary tangles. And they're just kind of these little black-brown spots that they'll see on brain tissue. Now, the speculation is that this is due to head trauma and concussion injuries, but we don't have, very conclusive proof that that's legitimately the cause, because we've seen the same condition in people with no history of head trauma. Mm-hmm. So if the condition is caused by head trauma, then how are we seeing it in people with no head trauma?
Do we see that as similar rates, or is there a massively different rate in those that have had head trauma or potential head trauma?
So the problem is, and this is kind of the big knock against the CTE literature, is that we don't have a lot of control brains, because typically the CTE studies are done through, brain bank type studies where people have donated brains. Well, the people that donate their brains are former athletes and people that are concerned that there's something going on. And so they'll donate the brain and they'll look in it. Oh yeah, we found a couple of spots of tau. And so we're going to say that, yes, this person had CTE. But we're not looking at the average Joe. People aren't just donating their brains for the fun of it, unless they've had head trauma, right? So we don't have a lot of good controls to know how frequent this is. We have had control brains in the sense that former athletes that have donated their brain end up not having it, even though they thought they did. And that happens the same in Alzheimer's disease, right? So Alzheimer's disease is another type of tauopathy. So tau in the brain can come from a variety of different causes. I think there's more than 20 different types of tauopathies. Now, I'm not a neuropathologist, so I'm kind of speaking out of turn, but I do pay attention to the CT literature. So there's about 20 different types of tauopathies. And so a lot of times people that are diagnosed with CTE, they'll have CTE plus other types of tauopathies. So the question is, okay, well, is this just a variation of a different type of tauopathy that we've always just assumed was something else, and now we're finding it, maybe in different regions or different patterning? The other question is that there's actually age-related tauopathies and neurodegenerative conditions. One's called RTAG and one's called PART, P-A-R-T. They have the same exact kind of clinical criteria as CTE. And so this is something we know. It's like an age-related neurodegenerative condition where the tangles are located in the similar parts of the brain as they are in CTE. So how many of these former athletes didn't just have these age-related tauopathies that we are discovering and we're calling it CTE and attributing to head trauma, but how do we know this wasn't just, normal living? How do we know that this was concussion injuries? So yeah, there's all sorts of controversy in this area. It's a very kind of hotly debated topic. The thing that bothers me the most about it is the fact that we're basically reporting on this, and the public assumes, and a lot of healthcare professionals assume, that the evidence is a lot stronger than it is. And so the media will report on this, and what starts to happen then is former athletes start to notice some of these signs and symptoms in themselves. Now, is that because they're actually there, or is that because they start to think, hey, you know what? I might have this, and maybe I'm not feeling quite as sharp as I was. And then they start to kind of maybe spiral a little bit and maybe develop some anxiety around this. And then now they start to convince themselves that they have this condition, and then they see more and more kind of manifestation of this. And then the thing, for example, a lot of these people will then eventually die by suicide and donate their brain. And then, half the time they don't actually have CTE at all, right? So that's the concerning part to me, is I think we have to be a little bit more balanced in our reporting of this. This is not something we can diagnose in living individuals, but there are kind of clinical criteria that we can say it's like suspected CTE. There's a new kind of diagnostic criteria that's like TES. It's like traumatic encephalopathy syndrome. So that's kind of the diagnostic criteria we would use for someone in life. And basically it used to be called suspected CTE because we can't confirm it until they actually die. But the clinical criteria is very loose, right? I haven't pulled it up in a while, but it's things like, oh, does this person exhibit signs of anxiety? That's one of the criteria. Does this person have self-reported, cognitive problems? Does this person have anger or explosiveness or depression? These are all things that can happen for a variety of reasons. And you could fulfill that diagnostic criteria. So for example, last year there was a study done. There was two studies. One was done on former NFL players, right? So former professional football players in the States. And when they ran the diagnostic criteria on those former football players, they found that the number of people, or the kind of the incidence of traumatic encephalopathy syndrome, was 7%. So they found out of 1,000 former football players, 7% of them met the diagnostic criteria for traumatic encephalopathy syndrome. Then they ran the same study looking at like just normal people in the population. Okay? Now, because the football study was only done on males, I'll only pay attention to the male category. Now, I don't know if you remember this study from the course, but what do you think? Do you remember it?
I think there was more incidence in the general population. Is that right?
It was 30.5%.
Yeah.
In the general population. So people with no history of head trauma, no history of sports exposure, no history of concussion or brain injury at all, 30% of males out of that 1,000 people population met the criteria for traumatic encephalopathy syndrome, whereas in former NFL players, it was only 7%.
Insane.
So what you could kind of conclude from those two studies is that playing professional football is actually protective against traumatic encephalopathy syndrome, right? Now, do those 30% of people have neurodegenerative brain conditions? Like, well, no, right? But do we know that all 7% of those do as well? And how many of the NFL players, how many of the other, 93% of those NFL players actually have the neurodegenerative condition, but actually don't display any signs of it, right? So that's the other kind of problem with this, is a lot of times people that have the symptoms show no evidence of it on postmortem examination. Other times, people with no symptoms show evidence of this on postmortem examination. So we don't have a strong correlation between the neuropathology and the actual clinical profile. So that's another kind of disconnect. So there's all these kind of problems where we're not, it's not super clear yet, right? And I don't want to come across as like a denier of CTE, because I'm not there. But I do think that we need to kind of cool it a little bit, because I do think that it is impacting people's lives, and people are getting very freaked out about this. And a lot of people are assuming that they have this already. I get emails almost daily from people being like, well, can you help me? I've been diagnosed as, probable CTE and da-da-da-da. And you're just like, well, there's a lot of things that can cause that type of clinical presentation. And unfortunately, because doctors are subject to the same media that we watch, and if they're not doing a deep dive on this topic, they're going to hear a patient come in and say, oh, I'm having all these problems, and I have a big history of concussion injuries, or I played a lot of football. They're just going to go, oh, it's this. And they're not going to look at all the potential other causes. Okay, well, why don't we treat your depression and your anxiety and see if that helps? Why don't we look at your hormone levels and your testosterone levels? Because there's all sorts of correlations here, like low testosterone, for example, is correlated with people that fit this clinical profile. Why don't we take a look at, can we give you some testosterone boosters? Can we get you onto a better diet? People with high body mass index tend to be higher on these issues because they have higher blood pressure. People with diabetes tend to be higher. So why don't we treat all these other potential causes and then go from there? But instead, we just label people this, and sorry, there's no treatment, and they end up in this massive spiral. So I'm not necessarily saying that CTE doesn't exist. I'm just saying that the evidence so far is limited. It's early days. And I think we need to just cool it on, making people think that we know more than we do, and that this is some sort of foregone conclusion, because I think it's actually ruining a lot of lives.
Hear, hear. I completely agree with you. I mean, I agree with you because I listened to what you said before, but yeah, I mean, it's terrible that we're basically damning someone and saying, you have this, there's nothing I can do, when there's potentially things that we can do for that person. Very sad. Mm-hmm. Which brings me on to really a big question for you. We've had your kids trying to break into your studio over the last hour. They're clearly having a lot of fun. And there's someone at the forefront of concussion research. Would you let your son and daughter play contact sports? And has your perspective kind of shifted as the science has evolved, or
Yeah, this is a really interesting question, because I would 100%. I have no kind of issue with that. My daughter plays hockey. Women's hockey is non-contact, but they still do get a lot of concussions. They actually get more concussions than the men's game, even though there's no contact. My son is starting hockey this year. I grew up playing hockey, and so I wouldn't pull them out of any of these sports at all. And the reason is because I don't think concussions are necessarily the problem. I think that the improper management of concussions is. And if you do get a concussion, right, it's like a broken arm. Like, yeah, okay, they could break their arm. Fine. But what are you going to do? You're going to take care of it, right? If you're going to be irresponsible with it and then let them break it again and again and again because you're not actually waiting for recovery to occur, then yeah, you're going to end up with a lot of problems. But ultimately, me knowing what I know, I'm like, well, if they get a concussion, I'm going to take care of it. I'm going to make sure that they're not going back. I'm going to make sure that they're doing baselines every single year. I've already started doing it with my daughter, right? Yeah. My daughter does all the balance stuff, all the cognitive, all the cognitive testing and stuff like that. So we already do that with them. And I'm not concerned at all with that right now based on where the evidence is at this point.
That's great to hear. I guess they've probably got the right person around them.
Yeah. Oh man, the amount of calls I get from other like parents being like, Johnny fell and hit his head. What should I be doing? And I'm like, yeah, I get a lot of calls from friends and things like that.
But it's great to see. I mean, it's great to hear. I mean, I kind of guessed you'd say that anyway, but I do have discussions with my friends who, kids are getting to that age, even just in taking part in things like football. And also let's not forget the benefits that those sports bring to kids as well, and what they might miss out on by not taking part of them in terms of their own development socially, physically as well. So I think there's a massive opportunity cost there.
Yeah, I think it builds resilience, it builds character. It's, you're facing adversity, you're, with a team especially, you're kind of winning and losing together and like all of that stuff. I think it just teaches so many kind of valuable lessons that can't be taught in any other type of environment. Now, you could say, well, you could do the same thing with non-contact sports, right? Like why not play basketball as opposed to playing football or rugby or that type of stuff? And that's a valid, point and argument. It just depends on what they really enjoy and what they really like to do. I mean, my son loves golf at this point. He's 5 and he just loves going and swinging golf clubs. So maybe golf is going to be his thing. I don't know. But if he wants to play football, I'm not going to say no, because I just don't think that. I think the risk is kind of somewhat, overblown. There's one thing I will say though. I think that there's this push right now in youth hockey in Canada. They've already done it. And there's a push right now in the US to just limit contact until a certain age. So like full-on tackle football starts in the US at like age, 6 and 7. And there's a push right now to make that age 14, where you can still play the game and still learn the skills and the techniques and everything else, but you're playing flag football until 14. I actually really do agree with that, because I just think that if there is a risk of having, the earlier you started contact football, if there is that association with, neurodegenerative conditions and things like that, even though the evidence is mixed, it's like, yeah, why not? Right. And there's no loss in skill development or anything like that. Like the same thing happened in hockey. So when I was a kid, hockey used to introduce contact at age 11 or 12. And now they've pushed that back to 16. And initially my thoughts were, I think this is going to create a huge problem, because these kids are not going to learn how to skate with their heads up, because that's one of the things you learn right away. When you're 11 years old and you start getting nailed because you got your head down still looking for the puck, you got to learn to be head up and just know what's going on with your stick, because you're going to get creamed if you don't. And the evidence actually shows that it didn't happen that way, where like once they introduced contact at age 16, there was a slight increase in concussion risk. However, the drop in concussion risk at the lower levels by removing it was actually way more substantial than the increase you experience at the back end. So it actually ended up being a great thing, and it didn't reduce skill development in any way. It kept more people in the game, because I think when kids start getting hit, they start being like, this isn't fun for me anymore, and they quit. So it keeps people kind of playing for longer. So I think there is some valid arguments to be said about, limiting contact exposure in young kids. But like from a concussion perspective, I mean, concussions aren't super concerning to me, to be honest, even as a concussion researcher. So,
No, but you're the best person to say that. I mean, I think the other thing is that doing the non-contact forms of the sport can actually teach other skills such as evasion better. You certainly see that in rugby, and in those countries where touch rugby is predominant in younger ages, they're often better at evasion, which potentially serves them better in avoiding concussions further down the line.
Right. It might be that game awareness scenario that I was talking about, right? Knowing where people are on the field, knowing how to dodge rather than, and then if I'm the risk-taking player, and if I grew up in a tackle environment, I might be more likely to just learn that I'm bigger than everyone. I can put my head down and run through them. But if you're playing an evasion game, you learn how to evade. And then maybe even though you would have been that person, maybe now you're not because you just learned to do that. And that
At least
becomes
you've got
your
options.
That becomes your instincts now because you've never been able to do this and you just have trained yourself now to do that. And so maybe there's something to be said for that too.
Is there something to do with head versus neck ratio in younger kids that puts them at any increased risk as well?
Yeah, well, that's a theory. So like kids are kind of bobbleheads, right? So kids have a large head on a small body. So I can't remember the stats I saw, but like at the age of like 4 or something, a kid's head size is 90% fully grown, whereas whereas the body's only like 30% of what it's going to be at the adult size. Yeah. And then even by age like 12, the kid's head is I think 95% fully grown and the body weight's about 50% of what they're going to be. So you still have like kind of it's harder for them to control, and that's another theory. But another theory for concussion risk in kids is just like a lack of myelination. So myelin is the fat that goes around the brain cells within the brain, and as that myelin layer develops, your brain becomes kind of more solid and resilient because you have more kind of protective padding within it, and can kind of prevent some injury. Well, like full myelination doesn't happen until you're like 25 years old or something like that. So there is, potentially that's why kids are potentially more susceptible to injuries. Maybe it's something to do with head body size ratios, or maybe it's something to do with myelination, or maybe it's a combination of, kind of both things.
Okay, got it. Cam, we've had a lot of information so far. Now is your real chance to kind of get on your soapbox. Not that you've not been so far. And the first section is called the Magic Wand section. So essentially, if you had one wish for the community of people listening, engaged in sport, potentially at risk, with regards to concussion care, or one wish for clinicians listening, what would that wish be?
I think would be for them to... Can I only have one?
Okay,
lots.
How about this?
No.
I'll give you maybe one for clinicians and one for the public. How about that? Or one for the potential patients.
I think one for clinicians would just be to develop a strong understanding of this injury so that you can provide accurate information to your patients. Because I think that patients come away with a ton of nocebos from clinicians who've, they basically perpetuate the same kind of media stereotypes. They tell their patients to rest in dark rooms, even though that hasn't been a thing since, the late 90s. They tell them to avoid stimulation, which again is like, very counterproductive. It actually makes people worse over time. And all that comes from them just having a lack of knowledge and education. And all they're doing is perpetuating the same kind of wives' tales that have been out there forever. So that's kind of, I think, on the clinician side. And again, another part of getting educated is learning that symptoms don't correlate with recovery, right? And learning like to do objective testing, to actually use a stepwise approach and physical exertion testing and going through proper protocols to actually ensure brain recovery. Because I think if we could take care of concussions when they happen, we wouldn't end up with all these downstream effects that I think we're seeing. I think that a lot of it could be mitigated by just having proper care, proper management. And I think that all starts with really getting up to speed on concussion. I mean, this field is changing so rapidly. We update our course basically every year with all the latest information. And what we were doing 3 years ago is now completely out of date. And so I think you have to kind of really stay on top of it if you want to do that. There's probably 400 or 500 studies a month now published on concussion. We have a team that goes through them all every single month. And
I was wondering how you did it.
Well, so it's me and three other people that literally go through every single study published every single week. And every Tuesday we meet, we go through all of them, and then we separate them, and then each one reads a few of them. We bring them back and we summarize all of them and put them in. So any clinician who's practicing full time just doesn't have the time to read that, which is why we've developed our course and training so that we can kind of take all that information and give people actual like evidence-based, here's everything we currently know. And then every month, all of the clinicians within our network, as you know, they get their monthly research updates so that they can stay on top of it without having to do all that work that we're doing for them. So they can just kind of quickly, okay, here's how things changed. Here's what's still the same. Okay, good. You just kind of keep up with everything. So that would be my wish for the clinicians, is to just really get educated, get up to speed, stop spewing the, media wives' tales that that you've heard for years, dark rooms and that kind of garbage. You're making people worse.
And for patients or potential patients, or for the public in general?
I'll go for parents and athletes first. So for parents and athletes, I think that, again, the concern is not necessarily that your kid might get a concussion, because the concussion isn't the big deal. It's how are you going to manage it when it does happen, right? And so I think that if you're going to play sports, I think that parents should be taking their kids for proper baselines, right? Not just a scat, right? You need to do like a comprehensive baseline with some neurocognitive, some balance, some stuff that from people that really know what they're doing. Because there's a lot of tools out there that people will use, and they'll use like one test, right? Like, oh, I do a King Devic and that's my baseline. That is not going to be helpful for you in any way. You need to have like a battery of tests. Yes, there's a cost, but it is so worth it if something happens. It's kind of like an insurance policy, right? You're going to do it. You hope you never need it. But if you do, you're so glad that you actually had that information, because now you can make proper kind of decisions. So I think for parents, it's not being concerned about concussion. It's just understanding that if you are going to be doing contact sports or things that do have a risk of concussion, you should be getting a good baseline test every year, and you should be find a clinic that really knows what they're doing that you can work with in the event that something happens. And then for patients, I'll talk about this from a PCS perspective. For patients with PCS, the big thing I want them to understand is that it's treatable, right? This is not a reflection of ongoing brain injury. They're always looking for someone who's going to do brain scans and look inside my brain and figure out what's going on. And that's not going to be where the answer is. The answer is either you have autonomic dysregulation, you have inflammation, gut issues, and hormone dysregulation, you have a visual or vestibular issue, you have a neck issue, or you have a lot of anxiety and mental health, or you have a combination of 3 or 4 or 5 of the 5. And they're all contributing to your symptom profile. And so I just want people to understand that this is not a death sentence. This does not mean your brain is damaged. This does not mean you're going to have CTE or that you already do have CTE, because a lot of people confuse those things. They think that once they've had persistent symptoms for 3 or 4 years, that then now they have CTE. Yeah. No. They're completely different things. This is no longer brain injury. This is simply systematic or dysfunctions in these systems that are fully treatable. And it's just a stepwise approach, and it can happen very quickly. It's very simple once you kind of understand how it works. It's obviously a very difficult process for the patient, because they have to kind of do things that are going to make them uncomfortable. They're going to make them symptomatic a little bit, but they have to be willing to kind of do that. So it is treatable, and that's kind of what I want patients to know.
I was going to ask you your pet peeve, but I think we've been through a lot of pet peeves today. Is there one that you want to kind of re-offer? Or do you feel like you've covered a lot of things that kind of wind you up in this space?
The one that's been really bugging me a lot lately is PCS patients being told by their doctors that once it's been a certain amount of time, then now it's permanent, and this is just your new normal, and this is how you have to learn to live with it now. And that's such bullshit. There's zero evidence. Like, there's not even a paper that suggests that. But yet people get told this all the time. And the time is always different, right? Somebody will go to a neurologist, and they'll be like, oh, once it's been 6 months, that's it. There's really nothing you can do. And, this is your new normal. Get used to it. And then they dismiss them. Other people, it'll be 3 years. Same story. Other people, it'll be 5 years. Oh, you didn't hit the 7-year magic window. So there is zero evidence to say that at all. I don't have no idea where people are getting this. And all I think that is just a reflection of like their lack of knowledge, right? Like if a neurologist doesn't really understand concussion very well, and a lot of them don't, and a lot of people think, well, they're a neurologist, they understand the brain, they understand neurology, but PCS and persistent concussion symptoms is no longer a neurological problem, right? When you go to see a neurologist, they're going to do a neurological evaluation on you, and your neurology is actually normal. And so they're going to be like, I don't know what to do here. So they're dismissing you without actually saying, I don't really know what I'm doing when it comes to persistent symptoms. I don't know how to treat it. It's not really my expertise. Instead, they say, well, how long has it been for you? 6 months? Well, that's about it. Once it's been 6 months, that's the end of the line. That's as good as you're going to get. Now for them, it's like an ego saver, right? I don't have to admit that I really don't know what I'm talking about here. I can tell the patient that that's just it so that they leave me alone, right? If there's nothing I can do for them, then they stop coming to me and I can just move on with my life and forget that patient altogether. And for the patient though, they're like, this is a neurologist. They specialize in this. They think that, okay. And then they take that and they internalize that. Yeah. Right. And so we get comments on our ads all the time being like, you can't treat a concussion. My neurologist says that it's permanent and I have CTE and whatever. And I'm just like, oh my God, I just feel so bad for these people to just be given this like incorrect information. So that's a real big pet peeve of mine right now is just giving people literally things that are based in no scientific reference whatsoever.
I'm really pleased I asked you because I feel like that was therapeutic for you as well.
Yeah.
Dr. Marshall, I've really enjoyed this discussion. It's been re-enlightening for me. I mean, I've heard it before, but to hear it again, it reinforces so much of what I've already learned. But I think it's also been very reassuring and I'm sure enlightening for the people listening as well. And I think pretty reassuring is a key word here. I think we now know there's things we can do to assess at the time. We have a greater framework of assessment to decide about return to play. And there's definitely things we can do for persistent concussion symptoms, let alone casting a little bit of shadow on the idea of CTE and at least keeping our minds open about the potential that maybe we're not putting people at the huge level of risk that we might thought chronically down the line. At least let's have our eyes open and let's not jump on media narratives.
Yeah, I mean, I think that goes for a lot of things, right? Like I think most of what you hear in the media, it's not quite the whole thing, right? We're going for sensationalism. We like the clicks, we like the ads, and more people that click on the story, the more ads we can sell. I mean, even I'll just, before we wrap here, there's a study that just looked at CTE positive studies, meaning that studies that found like a positive association either between concussion and CTE or football participation in CTE or whatever. Those positive type studies get 10 times the media coverage that the negative studies do. So if you have a study that shows there was no association between playing football and, neurodegenerative disease, there was no association between playing football and like all outcome mortality or anything like that, anything that kind of sheds a positive light on it gets 10 times less media coverage than the ones that show an association. So for the average person in the public, you're getting 10 times more information that's showing this positive association. So you're starting to assume that, well, why would they be reporting on this if it wasn't the case? Well, you have this balance of evidence, but when you're reporting one side 10 times to a greater extent than the other side basically gets nothing. And even when you look at Twitter, like retweets and stuff like that, 10 times the tweets and retweets and whatever, and 10 times the sourcing from other papers, but it's usually the same authors sourcing their own references from the previous studies.
Brilliant.
So these studies that show an association get referenced 10 times more. They get 10 times more media coverage, 10 times more tweets and retweets than these ones. So that's where everyone's mind goes. But meanwhile, over here, there's a lot of evidence on the other side. So I think we just have to have a more balanced approach to all of this stuff.
We do love a bit of negativity, don't we?
Everyone.
God,
Everyone.
Unbelievable.
Just think of what your news is.
Yeah, it's horrendous. Yeah. But let's leave it on a positive note. It's been it's been positive to vent. It's been positive to hear this really good news as well. So where can people find you? How can they find you on if they want to learn more, if they want to do your training, how do they go about that?
Our website is CompleteConcussions.com. If you're looking for treatment, if you're a patient, if you're a athlete, if you're a somebody who wants to get, good baseline testing or find a good clinic in your area to work with, you can go to CompleteConcussions.com, and there's a whole list of all of our clinics there. They're on a map. You can kind of geolocate it to your area. And then if you're a clinician, you're interested in, doing the training and getting yourself up to speed with everything we know about concussion. I think there's elephants upstairs in my office. My kids have a play date right now, so it's just craziness. But, you can go to CompleteConcussions.com, and if you go to courses, you'll see we have courses for physicians, we have courses for trainers, we have courses for PTs and chiropractors and all sorts of different health disciplines. So you can take a look at that. If you're looking for concussion software and good testing tools, we have those too. We have an application that you can use PitchSide, where it allows you to do neurocognitive testing, postural sway testing, and we're adding kind of more things to that to create a more comprehensive battery that you can use PitchSide. And then we have some pretty cool clinical tools as well.
Dr. Marshall, Cam, thank you so much. I've really enjoyed it.
Yeah, me too. Cheers, Matt.
Cheers.